So good morning. Yidnakacho, can you hear me?
Yes, doctor, we can hear you.
Yeah. Okay, good morning. So I'll be talking on a topic of stopping tyrosine kinase inhibitor therapy in CML patients and the associated treatment-free remissions, which is becoming one of the mostly discussed topics in hematology currently. So this will be my outline of presentation. So I'll have some background, followed by description of what the concept of treatment-free remission is and how it was proposed. And I will discuss some of the landmark treatment-free remission studies, and I will also discuss factors which can predict the success of treatment-free remission, and I will finally have a summary of all the things that we have discussed, and I will implicate some of the newer strategies to improve treatment-free remission. So as a background, chronic myeloid leukemia has been considered as a model disease in oncology for years because of many reasons. And discovery of the reciprocal translocation of translocation 922 as a hallmark of CML has ushered a new era in cancer research, and it provided a genetic link to cancer. So before the discovery of translocation 92, the link between genetics and cancer was not that much clear. So this is Professor Janet Rowley. She was the lady who have described that the cause of CML is the translocation 922. So she was the one who discovered that Philadelphia chromosome is because of the translocation 92, and that was responsible for the pathogenesis of CML. And this is a picture showing her getting an award from the then president for her incremental work in describing cancer is a genetic disease. And she got actually the Presidential Medal of Freedom in 2009, which is the highest recognition in the country. So discovery of this causative and functional lesion of CML, BCR-ABL, has paved the way for development of targeted therapies, as you know. And it is believed by many that tyrosine kinase inhibitor discovery for treatment of CML has been one of the great success stories of modern medicine. So subsequently, TKIs have changed the natural course of CML. So CML, once upon a time, was a disease which would kill patients in like 5 to 7 years because of the inevitable progression to blast crisis. But now we consider CML as a disease, a chronic illness having a life expectancy comparable to the general population. So this is a Swedish study which have shown that CML patients nowadays are having a life expectancy which is comparable to the general population. So you can see that after the Gregorian millennia 2000, because of the advent of TKIs, the life expectancy of CML patients has dramatically improved, and now it's almost approached that of the general population. And you can also see that this is more pronounced in the younger patients compared with the more elderly patients. So while CML patients are fortunate enough to have an excellent therapy to control their disease, most patients have a decreased quality of life because of the indefinite lifelong treatment. So TKIs, as we know, currently are given indefinitely, so this has an effect on the health-related quality of life of patients. So this is an Italian study which have looked into the quality of life of patients with CML compared with their age-matched general population. So you can see that when the score is less than 0, it means the CML patients are doing bad or worse than their compared with the general population. So especially for patients who are younger than 60 years of age, you can see that the CML patients, both in regarding physical health as well as mental health, they have a compromised quality of life. And this study reported that 82% of the patients reported fatigue, and that was the commonest side effect reported. And a third of patients reported severe symptoms of edema, musculoskeletal pain, muscle cramps, and so on. So this is just to show how the health-related quality of life of patients is compromised. But apart from compromising their quality of life, tyrosine kinase inhibitor is one of the most expensive cancer therapies in the world. I just brought this to show you how expensive tyrosine kinase inhibitors are. So even when you look at like the relatively cheaper Tki, which is the first generation Tki imatinib, it costs around $92,000 in the United States. Cost looks slightly better in the European countries, but it still costs around 40 to 50,000 USD annually. So consequently, the ultimate goal of CML therapy has to be to cure a patient, which ideally means to be off treatment and still have no evidence of disease thereafter. So this is what the idea of treatment-free remission means. So can we really stop treatment, and can patients still be in remission throughout their life? So how did they propose this idea? So how did the concept came? So as we all know, in the older days, the treatment of CML, the curative treatment of CML used to be allogenic hematopoietic stem cell transplantation. So during that time, people had an observation. So years after allogenic stem cell transplantation, many people were having residual disease. So many patients had detectable levels of BCR-ABL positivity, but they otherwise had no other evidence of disease relapse. So they stayed in remission, but still they could have some degree of BCR-ABL positivity. So these people have described 56% of BCR-ABL positivity, like 3 years after allogenic stem cell transplantation, but only 8% of them relapsed. And other people have seen that 1/4 of patients had detectable level of BCR-ABL positivity, but only 10% of patients relapsed. So this data suggests that molecular relapse in CML years after bone marrow transplant may not necessarily be a harbinger of disease relapse. So patients could still have detectable BCR-ABL levels, but this does not mean that they will all relapse. And the observation brought the concept of functional or operational cure. So by operational or functional cure, we mean patients could have circulating leukemic cells in their blood, but still these patients can theoretically or operationally be considered as cured because they will not have other evidence of disease relapse. So do we have a proof of concept? So what are our evidences to say that patients can stop the tyrosine kinase inhibitors and can still have a remission-free survival? So people have done several studies to confirm the feasibility of stopping tyrosine kinase inhibitor in carefully selected patients with CML. So this is the very first study, the pioneer study in Tki discontinuation trials or TFR studies. It's called the Stop Imatinib trial, the STEAM study. So what they did was they took 100 patients with CML and all of them were in chronic phase, and they started imatinib, and patients should have been treated with imatinib for at least 3 years. And then they should have a BCR level, which is undetectable for at least 2 years. And by undetectable, we mean the detection limit of the kits they used was 4.7 log reduction. And then after that, they stopped the imatinib and they followed the patients after stopping the imatinib. So, but during the discontinuation phase, they were checking the BCR-ABL level every month for the first 1 year. And then after that, they were checking the BCR-ABL level every 2 months to see if patients are relapsing. So relapse was defined as any detection of BCR-ABL on 2 consecutive levels, and between the two, there should be at least a 1 log increment between the two. And if that occurs, patients will have a resumption of the imatinib. So what they found was, so they followed patients for around the median duration of follow-up was 77 months, which is around 6 years. So the molecular-free survival or treatment-free remission at 6 months was 43%. And at 60 months, almost at 5 years, was 38%. So at 5 years, near to 40% of the patients did not have a molecular relapse. And you can see that the relapse occurs most of the time at this, until the first 6 months. And after that, it kind of plateaus, the curve kind of plateaus. So most of the relapses occurs in the first 6 months, and delayed relapses were not common. So overall, from the 161 patients had relapsed, and the median time to relapse was only 2 months, and 57 patients were retreated with imatinib. And the good thing is most of them, 55 of them, had achieved a second undetectable level of their molecular disease when imatinib was resumed. So the other study is the STEAM according to STEAM study. So this is almost similar to the previous one, but the only difference is to resume imatinib or to label patients as a relapser. They took loss of major molecular response, which is a log3 reduction BCR-ABL level. So they use a less stringent criteria to reinitiate imatinib. Again, what they found was the treatment-free remission at 24 months was 61%. So this is slightly higher than the previous number because they used less stringent criteria to reinitiate therapy. So 36% of the patients lost their major molecular response, so they relapsed. But again, on resumption, all of the patients have resumed their major molecular response when imatinib was reinitiated. And then the other and the more recent trial is the EuroSky trial. This is the most important one because of it's one thing. It's because it is the largest TFR study today. Until today, it's incriminated around 800 patients. 758 patients were incriminated, and it also incriminated patients who were on imatinib as well as the second generation TKIs, nilotinib and dasatinib. So this used even less stringent criteria to include patients. So they wanted patients to be in MR4, which is log4 reduction of their BCR-ABL level, only for 1 year. And patients should definitely be on TKI therapy for at least 3 years. And they stopped therapy, and then they followed patients for at least 3 years. So what they found was, again, the treatment-free remission they found was almost comparable. 52% of the patients were still in treatment-free remission at 24 months or at 2 years. And 49% of the patients relapsed, but 80% so most of the relapses, again, similar to the previous studies, occurred in the first 6 months of discontinuation of TKI. But what is more also interesting about EuroSky is they also reported the cost analysis. And when they considering the amount of the cost of imatinib at that time and the duration of TKI, the duration of the time that imatinib was discontinued, they estimated that discontinuation has saved around 22 million euro because of the discontinuation. So this is a huge cost when you think of the cost. So these are some of the stages of discontinuation in imatinib, but how about the second generation tyrosine kinase inhibitors? So what does the result looks like when second generation tyrosine kinase inhibitors are stopped? So what we know is second generation tyrosine kinase inhibitors, the ones which apart from imatinib induce a deeper response in a shorter period of time. So this has been described from the older studies. So one of the advantages of second generation TKIs is they will take patients into deep response and in a very short period of time. So theoretically, it means we have seen that to recruit patients into TFR studies, you have to have a deeper response. So theoretically, this gives us the insights that second generation TKIs may increase the number of candidates for TFR. Again, several studies have shown the feasibility of discontinuation of nilotinib and dasatinib. So this is the stop second generation TKI study. So what they did was they took patients who were on nilotinib or dasatinib because of imatinib intolerance or resistance, and patients should have been treated with these treatments for at least 3 years, and they should have been in log 4.5 reduction for at least 2 years, and then they stopped the nilotinib or the dasatinib. So, and then followed patients for at least 5 years. So again, what they found was at 1 year, 63% of the patients were in treatment-free remission, so they did not relapse. 43% relapsed. Again, when they relapsed in the very short period of time. So the median time to relapse was 4 months. So this is almost similar to what was found in the previous imatinib discontinuation studies. Another INEST freedom study, this is maybe the most recent one. It was published this year in February. So they took patients who were on frontline nilotinib, and then patients should have been in log 4.5 reduction for at least 1 year on nilotinib, and then they discontinued the nilotinib. Again, the treatment-free remission at 5 years was 42%. So almost again similar to the previous studies. So this is just a table to summarize the TFR studies that we had, the most important TFR studies that we had. So when you look at the treatment-free remission rates from the different reporters, so they use different criteria to recruit patients to reinitiate therapy by labeling as a relapse and so on, but more or less 40 to 60% of patients would remain in treatment-free remission after you discontinue TKI therapy. So this is around 50% of patients would remain in treatment-free remission, which means the rest 50% will have a relapse. So why do we have different outcomes after TKI discontinuation? So why do some patients relapse and why do some patients will remain in treatment-free remission? So the logic behind is when you treat cancer, so especially hematology cancers, you have the normal hematopoietic stem cells and you have the leukemic stem cells. So when you stop TKI, there are two options. So either the hematopoietic stem cells, the normal ones, will take over, and these patients will definitely not have a remission. But the unfortunate patients who will have the leukemic stem cells taking over after discontinuation will have a relapse. So why this occurs? Different things can be incriminated. So the hematopoietic niche of each individual would be different. The stem cell properties from individuals to individuals may be different, and the immune response could also be different from patient to patient. So this is, people think that this is why patients have different outcomes after TKI discontinuation. So other important thing is what factors predict successful treatment-free remission. So can we know which patients would less likely to have a relapse after discontinuation of TKIs? So different studies have shown different characteristics to be associated with successful treatment-free remission, but the unfortunate thing is none of them have been consistent. So some of the studies proposed some characteristics and the others different. So some of the important factors which were shown to be associated with treatment-free remission until today are age of the patient. So some studies have shown that elderly patients are more likely to have better treatment-free remission than the younger ones. So-called score of patients. So the higher the so-called score, the less likely the safe TFR would be. Duration of TKI therapy before discontinuation. This is actually very, very important. So the longer the patient had been on TKI therapy before discontinuation, the more likely that TFR would be successful. Duration of deep molecular response. So the more the duration of the more that the duration of deep molecular responses, the more likely that your TFR success will be high. And previous TKI resistance. So especially patients who had been switched to second-generation TKIs because of imatinib resistance rather than imatinib intolerance would do bad regarding TFR. So these are some of the factors incriminated from the same trial. You can see that patients who had been on imatinib for at least 50 months do way better than patients who had been on imatinib for less than 50 months regarding relapse risk. And patients with a high so-called score are the ones who do the worst regarding treatment-free remission, and the low and the intermediate risk patients would do okay. And regarding second-generation TKIs, patients who have been switched to second-generation TKIs because of suboptimal response or resistance would do way bad than patients who had been changed to second-line therapies because of intolerance. This makes sense because patients who are switched because of resistance generally have, biologically, they have a more aggressive disease. So how safe is to attempt TFR? Definitely, we have seen that when you stop TKIs, there is a risk of relapse, but what other risks does it have? So one of the fears is resistance on resumption of TKIs. So, but the good thing is this has not been reported until today, except in one patient in the Ernest stop study. So most of the patients who have stopped therapy, when you reinitiate the previous TKI, they would respond, and TKI resistance has not been reported except in one patient. The other fear is, would patients progress to accelerated phase in blast crisis when you stop TKIs? Again, this has not been reported except in one patient in the STEAM study. So again, in this patient, even the patient progressed to accelerated phase after she was in after she regained her major molecular response. So we are not sure if she progressed because of the discontinuation or just because this was the natural course of her disease. But the other new entity which is being described is Tki Withdrawal Syndrome. So this is a new entity which have been witnessed in patients who have discontinued TKI therapy. So this is a kind of benign transient condition with mainly musculoskeletal pain and arthralgia soon after discontinuation of TKIs, and it is part of physiologic mechanism is not that clear. So patient is present with what looks like a polymyalgia rheumatica symptoms, and it has been described in 30% of patients. The good thing is patients usually respond for analgesics like paracetamol and so on, but few patients had severe symptoms. So these are the general suggested criteria to try TFR. So so-called scores, so they recommend, like the green lights are, you can definitely try TKI discontinuation. The yellow ones are, you have to be careful, and the red ones are, you should never try TKI therapy in this kind of patient. So if so-called score is non-high, intermediate, low risk patient, you can try TFR. PCR reveal transcripts, the usual ones, the typical ones, you can try TKI discontinuation. Past CML history, if the patient had history of chronic phase only, you can try. But for prior accelerated phase blast crisis, we don't try because patients were excluded in the TFR studies if they had accelerated phase or blast crisis. Response to first-line TKI therapy. So if the response for initial therapy was optimal, that is a green light to try TKI discontinuation, but if patients with history of resistance should not be tried. Duration of previous TKI, so the best is if patient had been treated for more than 8 years, but anything between 3 and 8 years you can try, but with caution, but no patient should be tried on TFR study if they have been on TKI therapy for less than 3 years. And the depth of molecular response, so how deep was the molecular response before discontinuation? So the best is like log 5 reduction or MR 4.5, but in log 4 reduction also you can try, but that should not be tried in patients. Log reduction less than 4. And duration of deep molecular response, so patients should be in this deep molecular response for at least more than 2 years. But if they are in 1 to 2 years, you can try, but with caution, and no patient should be tried if duration of deep molecular response was less than 1 year. So as a summary, we definitely are entering a treatment-free remission era. So TKI discontinuation has become the current paradigm of CML, and people are talking a lot about it. And when you look at like seminars and so on CML, TFR is becoming a topic of utmost importance in CML. And to date, we have more than 2,000 CML patients who have stopped treatment worldwide. And as we have seen, so far, almost all of the patients who have relapsed on discontinuation remain sensitive to TKI resumption. So the good thing is, if your patient relapses, you can resume treatment. And patients, almost all of the time, they would respond, and resistance has not been reported except in one patient until today. And so being able to discontinue tyrosine kinase inhibitor is quite exciting for the patient, as well as for the health system generally, because we have said that TKIs are very expensive drugs and so on, and patients also suffer from the quality of life compromisation and so on. It's quite exciting, but it should only be done in centers which fulfill requirements to stop. So, and including, we have to have a standard rate sensitive PCR, and we have to make sure that we will monitor patients after discontinuation very closely. So otherwise, patients are enjoying a life expectancy as comparable to the general population. So we don't want to give these patients unnecessary risk unless we are sure that we do it in a very strict manner. So these are the recommendations from the major CML guidelines currently. So the ALN, the NCCN, and the ESMO guidelines have more or less similar, but slightly different recommendations. So TFR generally is recommended for patients more than 18 years, adult patients. And as we have said, it should be tried for only chronic phase patients. So-called score, most recommend to do it in non-high so-called score patients. And BCL transcripts has to be the usual ones. And response to first-line TKI therapy, as I have said, they have to be patients who have responded for TKI therapy. Duration, they use different recommendations, but at least 5 years of, at least 3 years definitely required, but some recommend 5 years of TKI therapy before discontinuation. Depth again differs between them, but the best is if you had a log 4.5 reduction, but with patients who had a log 4 reduction can also be tried. Duration of deep molecular response, most recommend at least patients should be in deep molecular response for at least 2 years. And frequency of monitoring is the most important one. So when we recommend, we have to make sure that we will check the BCR levels for at least the first 6 months, every month, and then for the next 12 months, at least every 2 months, and thereafter, for the life of for the life of the rest of the life of the patient, and every 3 months, PCR level should be checked so that the patients are picked early for relapse. And they say PCR turnaround time has to be within 2 weeks, and resumption should be done within 4 weeks of a major molecular response loss. So unless these things, we're sure that we can do these things, they don't recommend to try TFR or discontinuation of TKIs. So with the current approach of TKI discontinuation, like it's far from being optimal. So they say that only 20-25% of the whole CML patient population can get and maintain TFR. So the criteria to recruit patients are strict, and the number of patients who will stay in TFR are also limited. So with this, only 20-25% of patients will have a successful to get into the TFR trial and also to be successful. So the rest, 80% of the patients of CML, again, are expected to stay on their TKI therapy for life. So people are seeing newer strategies to increase the success of TFR by de-escalating treatment before discontinuation instead of abrupt cessation. So can we taper the treatment before abruptly discontinuing and increase the success of TKI? This is a Destiny trial. So what they did was, before totally discontinuing TKI therapy, they decreased the dose of TKI therapy for 1 year by 50%, and then they stopped totally for 24 months. So, for example, if patient was taking imatinib 400 for 1 year, they made it for 200 milligram, and for another 2 years, they totally stopped it. And this seemed promising, and the recurrence-free survival, treatment-free survival was 72%. So this was slightly higher than the ones that we have seen. So the ones, the TFR studies, all the TFR studies reported 40 to 60% of TFR, but this had a higher rate of TFR. And the reason for this is not very clear. So why do patients do better when they were de-escalated and then stopped? Then abrupt stopping needs further study, but at least the observation looks like this. This is another study, a recent study published in January. So these people did de-escalation of therapy rather than discontinuation. So they would put patients for 1 month on TKI, and then for another month, patients will be off. And then the next month they will be on TKI, and for the next 2 months they will be off, and the next month they will be on TKI, and the next 3 months they will be off therapy. So it's a kind of decreasing the time that the patients will be on TKI. Again, this was promising. 81% of the patients maintained their major molecular response by doing this. So maybe in the future, right away discontinuation may not be that much successful, but the de-escalating therapy may be what we need. So in conclusion, so we have convincing results from CML studies, and these have validated the concept of TFR, and which have become the main clinical criteria for clinical trials. And CML, again, will continue to be a model disease in hematology and cancer as a whole. But now the subject of disease curability is the next step to reach for all patients. And we are kind of going to the concept that CML can be maybe like the first disease which can be cured by targeted therapy. Thank you. And if you have questions.
Dr. Foziya.
Yes, Doctor.
It was a very nice presentation. I have a few
Okay.
questions. One is, I understand how difficult the condition is, but role of epigenetics. What it means is, the BCR ABL but the surrounding environmental conditions, the epigenetic, is it well described? And the other thing is it a cure now? Is it a prospect for cure?
Yeah.
Of CML? Thank you.
Yeah. Yes, okay. Thank you, Dr. Anderson. So, yes, so people are describing apart from clinical factors, so there are some biological factors, like the microenvironment of the marrow is also incriminated as a predictor of successful tyrosine kinase inhibitor. So people have seen patients who have more natural killer cells, more T cells in the marrow and so on are said to have a better success of discontinuation of TKIs. So nowadays, apart from clinical factors, they are trying to see the biological factors, as you have said, also the epigenetic factors, which will predict treatment-free remissions. But I think we need to have more data on that. And regarding like is it a cure? Yes, so we definitely are going to that line, but we have to know that cure is not, like treatment-free remission is never equivalent to cure, because we have seen that patients still have residual leukemic cells. So why is it difficult to cure hematologic malignancies generally is because of the leukemic stem cells that patients will still have. So leukemic stem cells, unlike the other hematopoietic stem cells, are not dividing cells, and it's very difficult to attack them with, they are very dormant cells, residual cells, so they still will continue to proliferate after you discontinue therapy. So we definitely are going to the era of possible cure, but cure has to be in quotation, because patients in treatment-free remission you can never know when they would relapse, but it looks like if they relapse very fast. But I would say TFR should not be taken as an equivalent of cure. I'm not sure if I have addressed the...
Very well addressed. Thank you.
Okay, thank
you. Can you hear me?
Yes, Dr. Abdella.
Yeah, Foziya, this was excellent. And when we discussed about the topic, I was worried to present it in this forum, but you did it excellent. So, so there were questions regarding local experience and so on. You would add on that, but as you have seen, to say about local experience, as you have seen, TFR requires a very robust system, like in terms of patient monitoring. So most of our patients, to be very frank, most of our patients, we follow them with CBC. So this is a crude way of follow-up. Only few patients would have repeat BCR-ABL. So although we have some patients who could qualify for that, the setup is not ready for that, because we cannot provide BCR-ABL, which is usually outsourced, and sometimes the kits we have it, but it's not, we don't have it in a very reliable way. So we are not thinking of TFR very soon in the near future in here. So if I give you some experience from some centers which promote TFR, in Adelaide, Australia, they have around 40% of TFR, but they do it only after discussion with the patient, and some of the physicians are hesitant about it, and some promote it. So not all of the 40, around 5% of their patients in TFR. So even the best centers are are afraid of using TFR. So thank you.
Okay, thank you, Dr. Abdulaziz. So as it was mentioned by Dr. Abdulaziz clearly, so trying a TFR has to be done with a very cautious way, because as you can see, most of the guidelines recommend wanting to recruit patients, you have to make sure that they are in deep molecular response. And our patients, mostly we follow their hematologic response, so not their molecular response. And more importantly, after you stop, you have to make sure that you do the BCR well, at least for the first 6 months, every 1 month. So I think this is almost unthinkable in our patients. And for us, at least for the next few years, treatment-free remission might only be theoretical, but we don't know what future brings. So people are going on this line, and so I don't think this is going to be the way in our setup for the next few years, but it is very enlightening for the patients as well as for the health system as well. Okay. Idnaqacho, if there are no questions, I think.
Okay, Doctor. So I think there are no further questions. In that case, we can end up our morning session. Thank you, Doctor.